Okay, thanks for the kind introduction. I'm just gonna close this if it will. Oops. Okay, that's okay. I just can't see my cursor. I'm gonna try. Um,
That's actually one. Oh,
uh-huh.
gotcha.
Just will want to see what I'm doing. Perfect. Thank you. All right. I'll also close this one. Okay, so today I'm going to be talking about aging in the depressed brain. And I want to talk about a few things before we get into the concept of depression. But first and foremost, healthy aging is unfortunately associated with cognitive decline in a number of different domains. So actually, I don't know if this is working as well. Here we go. Perfect. So healthy aging is associated, like I said, with a number of different cognitive domains. So this is just a graph of normalized performance on a number of different neuropsychological batteries as a function of age. And as you can see, unfortunately, it will happen to us all. Various different cognitive domains are going to slowly but steadily decline, except vocabulary reasoning. But this happens in a number of different areas, notably memory, both episodic and semantic memory, executive function, so things like attention, task switching, working memory, and set shifting, but also things like impulsivity and sensitivity to rewards. Um, this is very interesting to me because this doesn't happen at the same rate in everybody. And, it happens in a variety of different cognitive or network-based areas or network areas and network circuits in the brain. And so the next question then became, well, how can we characterize some of these age-related changes in the brain? So what are some of the measurements that we use, both in my lab and in lots of others, to characterize age-related changes? And I'm going to talk about 3 today. For those who aren't neuroimagers in the room. The first is volume. And so in this case, what we do is we collect structural MRIs, T1 weighted MRIs. MRIs represent the brain as cubes or voxels, 3-dimensional little cubes. And we can decide based on the intensity of these cubes, essentially what areas of the brain are gray matter, what areas are white matter, and what areas are cerebrospinal fluid. We can then compare this to parcellations or atlases of the brain that subdivide regions structurally or functionally, and then ask, okay, well, what's the differences in volume, number of voxels in millimeters cubed from one person to the next? Now, the other way we can do this structurally is looking at cortical thickness. And again, we take the same kinds of MRIs that are in surface space, or excuse me, in volume space, and transform these into surface space. So instead of representing the brain as cubes or voxels, we then transform this into surface meshes, kind of similar to, I don't know, 3D animation. We have polygons there, but in this case, we've got these little triangles here, vertices and edges that represent the topography of tissue boundaries. And in this case, this one shown here, for example, would be the peel surface of the gray matter in the cortex. We can then also do this for the boundary, not just between the gray matter and pia, but also between gray matter and white matter along the cortex, and then look at the thickness or the distance between these two surface meshes to get a measurement of cortical thickness, simply put. Now, the other way we can do this is functionally. We can characterize the brain using functional connectivity. And in this case, we looked at functional connectivity, which is the coupling of distinct regions of the brain. In this case, I use resting state, which is spontaneous fluctuations in the brain, but this also happens in task-based activity as well. And the idea here is that the spontaneous fluctuations in fMRI signal from different areas of the brain are correlated over time if they're functionally connected. So to give you an example of this brain, we've got a couple of areas here shown in hot colors and an area in blue. And if I play this little video, you'll see that the areas in orange and yellow tend to go hotter or cooler increased in signal intensity or decreased in signal intensity at similar times, whereas the area in blue does kind of the opposite thing. And using this kind of information, we can discern intrinsic brain networks that tend to be structurally connected via mono or polysynaptic connections. And they're active not only at rest like this with their spontaneous fluctuations, but also during tasks. These networks, as I said, are functionally distinct. They're correlated over time, and they are discernible both at rest, when we ask people to sit in the scanner and think of nothing in particular, but also in tasks. They're also highly replicable over time in the same individual, and they're also discernible across participants as well. Of course, there's lots of inter-individual variability, but generally we do see certain canonical networks replicated across participants. So how do these things relate to brain aging? Well, first and foremost, we see steady nonlinear changes in gray matter volume and something called network modularity, which I'll get to in a second, correlated with age. So here are a couple of intrinsic brain networks that we care about, particularly in the context of psychopathology. The default mode network, which is implicated in autobiographical memory and rumination, sort of inward cognition. The salience network or cinguloopercular network, which is often involved with switching between these two states and it integrates sort of multimodal inputs and projects to premotor regions to assist with action selection. And the central executive network, which is often involved with things like working memory and executive function. There generally tends to be this sort of anti-correlation between these executive function networks and these sort of inward cognition networks, with the salience network sort of playing the fulcrum, I guess, of the lever between sort of inward generating thoughts and externally generating thoughts. And all of these networks, including others, exhibit decreases in gray matter volume associated with age. So again, here you can see gray matter volume in all three of these networks, and a pretty steady decline across age across individuals, with pretty robust heterogeneity in all of these networks. So each of these lines is a person. Now, what else? So we know that there are these reductions in gray matter volume, but what do I mean by network modularity? So in functional connectivity, we generally want our networks to be really strongly correlated within the network, but not as strongly correlated between networks. That is sort of the definition of modularity. And in young people, we see, we can discern very clearly a robust set of networks, and there do seem to be changes in which areas of the brain are ascribed to particular networks with resting state functional connectivity. And if you look over time, we see this is sort of a heat map here where you can see which areas of the brain are correlated with which, the diagonal here being correlated with itself. And again, in younger individuals, you can see that there's more connectivity within the networks that are color-coded here relative to between. And as individuals aged, we see that there's this breakdown of modularity across all these networks, with connectivity increasing between networks and decreasing within networks. Now, using graph theory and other measurements that sort of discuss characteristics of a network, we can quantify the level of networkiness of particular areas of the brain, which is shown in this slide, where we see that specific networks segregation index, which again is a measurement related to modularity, changes across the brain, both in a nonlinear fashion. And these changes are correlated with age-related cognitive decline. And so in this case here, this is a frontoparietal executive control network, and its change across age or across time in older individuals was associated with processing speed, which worsens as we age. such that a decrease in modularity or segregation of networks was associated with worsening processing speed. Now, in all of these graphs I've shown you so far, there's a lot of variability, which is always very exciting because it means that we can leverage this. So how do we leverage this in the context of brain aging? So the thought behind a lot of the brain aging work to leverage this variability is that the individual differences in brain aging may predict either risk to developing a disease, or severity of a disease, or poor prognosis to treatment. The idea is that if there was some insult, say this was like an episode of depression or head trauma or something else, it may change the trajectory of an individual, or there may be pre-existing conditions, genetic, other environmental conditions that may contribute to a faster age-related decline in brain-based measures. And the idea here is that it could be the case that these rates or individual differences related to healthy aging may yield more informative clinical characteristics than just chronological age itself. So how do we look at this? How do we look at brain aging? Well, we do a few things. Typically, and this has been done, I guess, for the last 10, 15 years now, is we'll take a large healthy sample across the lifespan, and we'll try to predict chronological age using brain-based measures. Those measures typically include brain volume or cortical thickness, both surface area of brain-based, of cortical regions, things like that. And so we'll build this machine learning model to predict chronological age. So this would be the chronological age and the predicted age. We would then apply this machine learning model to a new data set of individuals and then subtract the predicted age from the chronological age, such that if the difference is positive, then the predicted age is older than what you would have actually wanted, indicating an older or accelerated appearing brain relative to their peers of the same age. And a negative appearing difference, so if they were predicted to be younger, it could mean something protective. They have slower aging of the brain. The idea is we can use this difference, or the brain predicted age difference, to then look at outcomes or cognitive decline, behavioral measures, response to treatments, atypical brain PAD relative to controls. So this has been done for the last 10 years or so, with models getting more and more sophisticated as we approach today. But we have already shown in other clinical populations that brain aging and that brain predicted age difference may yield informative clinical utility. So here's a few examples. This is the mortality in older adults. And what they did was they just tracked older adults after a brain scan. They got their predicted brain age difference and just tracked mortality over time, just general mortality. Didn't matter the cause. And individuals that were in the upper brain PAD quartile, so the top 25% of individuals who had the oldest appearing brains, had higher mortality rates than individuals with less or diminished brain or decelerated brain aging. So just overall mortality in older adults is associated with brain aging. Here's another example of older adults with mild cognitive impairment. They just scanned people's brains with MCI and then just tracked who developed full-blown Alzheimer's. And again, individuals with older appearing brains, these red and green lines here, were more likely to convert from mild cognitive impairment to full-blown Alzheimer's relative to people who had normal or decelerated aging. The last example here is just objective cognitive impairment. And again, people with older appearing brains were more cognitively impaired. Now, what does this look like in depression in the context of aging? Well, I'm going to backtrack a little bit and just talk about why we think it's important to study this in depression. So depression is one of the leading causes of years lived with a disability across the world. And at least in Ontario, the province where I'm from, depression-related burden of illness, economic burden of illness, and personal burden of illness was greater than the combined burden of some of the top cancers combined. And depression, typically people are given psychotherapy or pharmacotherapies, drugs to treat their depression. And unfortunately, only about half of people who are diagnosed with depression will get better or no longer be diagnosable with depression according to current criteria within the first 3 months. And about a third of people don't get better after 3 treatments, sequential treatments of depression. So although there are many options available, lots of drugs, lots of psychotherapies available for individuals, unfortunately, we do not have a very robust and individually and prospectively predictive way of giving people the right treatment the first time. We also know that depression is associated with cognitive decline that resembles aging-related cognitive decline. So this is just a meta-analysis looking at certain cognitive domains. This block up here is attentional switching, verbal fluency, and cognitive flexibility. And as you can see, patients perform significantly worse in these cognitive domains relative to controls. And we think that some aspects of age-related cognitive decline may mediate specific symptoms. In this example, or moderate certain symptoms. And in this case here, impulsivity moderated the relationship between depression severity and suicidality, indicating that aspects of cognitive decline and disruptions in cognition that resemble aging may be mediating poor outcomes in depression. We also see resting state functional connectivity and other measures. Not only are they atypical in people diagnosed with depression, and in this case, these are older adults diagnosed with depression, but we also see that they're correlated with specific symptoms. In this case, this is an anhedonia scale, and this is a fatigue scale, but they're also correlated with particular cognitive domains and their atypical performance. So in this case, this is word recall. We've got some executive function measures as well as episodic memory. So number of individuals, including larger consortia like Enigma, have asked whether or not in depression we see if brain aging is accelerated in depression. And these are all using structural measures of the brain, predominantly volume of gray matter regions. And here you can see, I'll walk you through, these are 3 separate studies all looking at brain age in depression and other psychiatric conditions relative to controls. And some, but not all studies have shown a significant evidence for accelerated brain aging in depression. So in the sample or example to the left here, depression is in the middle here relative to controls. And in the example to the right here, there was also a small but significant increase in brain PAD in MDD relative to controls. However, in this middle example here, there was no significant difference. So one of the questions I wanted to ask and my group wanted to ask was, what about functional related changes in the brain? Are they showing evidence of accelerated brain aging, since this was not yet done? And furthermore, were these changes related to age and accelerated aging in treatment-resistant depression associated with executive dysfunction, as well as response to transcranial magnetic stimulation? So the first thing we did was we wanted to characterize just correlates with age. And we did this across the brain in a largish sample of healthy controls across the lifespan from 18 to about 90 years old, as well as a sample of depressed individuals. And as you can see, similar to before, we do see reductions in functional connectivity within networks associated with age and healthy aging, but also evidence of increased functional connectivity between networks in the depressed group. Now, the areas of the brain associated with age that were very different in depression and controls were areas that we typically see abnormal in depression. So this would be things like the orbitofrontal cortex and bilateral subgenual cingulate. The subgenual cingulate is often active when we feel sad, and it's a target of, simply put, and a target for deep brain stimulation as a treatment for depression. We also see limbic regions like the hippocampus and parahippocampal gyrus, as well as areas of cingulopercular networks like the dorsal ACC. We then built a machine learning model using the healthy control data, and we were able to identify a model that significantly predicted age using functional connectivity, which you can see here. So this is just the R squared of this correlation relative to permuted data, and here you can see chronological age and predicted age. So what were the most important features predicting age? Well, we were able to identify a number of top features and regions of the brain predicting age, but they were quite distributed. A lot of them were connectivity between networks, which I guess makes sense given the story so far. Increasing connectivity between networks across time and with age is associated with cognitive decline. And a lot of the top regions of the brain were ones that we typically see not only in depression, but also responsible for a wide host of cognitive domains implicated in aging. So the next thing we did was we applied our machine learning model to the depression samples functional connectivity data to see whether or not depression was associated with accelerated functional aging. And similar to before, we saw that indeed there was evidence for accelerated brain aging in depression relative to controls, such that individuals with treatment-resistant depression, there's a little bit of red right here, people diagnosed with depression appeared about 2 years older than controls scanned from the same site. So we were just controlling for site differences there, but they did appear older by about 2 years. So I think this adds to the notion that although this study wasn't significant, we do see a small but significant increase in brain age in depression relative to controls. Now, the next thing we asked was whether or not cognitive impairment was associated with accelerated aging. And so in this case, we used a questionnaire called the BIS-11, which is the Barrett Impulsivity Scale. And what we found was that people who had people with depression who had an older brain age also had impairments in financial impulsivity in particular. So items related to changing jobs, buying things on impulse, saving or spending money, things like that were associated with accelerated brain aging in this population. So in explaining this finding, we do see a lot of the areas that have come up in aging also associated with financial decision making. So on the left here, these are areas involved with impulsivity and delay discounting, which is a task often used to look at withholding rewards over time. And as you can see, the dorsal ACC comes up as one of those regions, sort of a recurring theme here, as one of the regions implicated not only in accelerated aging and depression, but also one implicated in impulsivity and financial decision making. We also know that economic decision making is associated with age, but specifically complex financial decision making. So things like simple decision making with respect to like paying bills and other sort of simple tasks tend to be intact as we age, but more complex decision making with respect to money is impacted by age. And here's just an example of how rewards are impacted by age, where we do see changes in insular activity to risks, financial risks impacted by age, but not reward anticipation. So there is evidence that financial decision making is different as we age, not only behaviorally, but also in terms of brain activity. We also wanted to note that other environmental factors might be at play here, especially when it comes to financial decision making. And this is an area of active investigation, but we also know that depression and other neuropsychiatric illnesses are associated with lower socioeconomic status. So individuals from a lower socioeconomic status background tend to have higher rates of depression and poorer prognosis. And SES is implicated in decision making with respect to rewards and money, and in the brain, things like network segregation, and that modularity as we age is impacted by SES. So this is just an example where that brain segregation measure decreases, is lower and decreases at a faster rate as we age in individuals from a lower SES background, indicating that this could be a potential confound in a lot of the brain aging literature, and something that we kind of need to explore more, better understanding the relationship between SES, accelerated brain aging, and some of the cognitive changes that we see as we age. So this was all with the brain aging stuff that I just showed you was all with functional connectivity. And after we published this, a nice validation came out using structural measures. This was a sample of depressed individuals. They also showed accelerated evidence for accelerated aging in the brain, but then they also had impulsivity measures, and found the same thing as we did using a different modality and a different machine learning algorithm, that accelerated brain aging was associated with impulsivity. So I was very happy about that. So the last thing I want to talk about this line of work before I get into some of the stuff we're working on now is treatment response and brain age. So is brain age and accelerated brain aging associated with treatment response in depression? So this is kind of a messy and rather small figure, but this is sort of the guidelines in Canada written by psychiatrists on how to treat people. And it's a little flow chart where most people, when they get depressed, they go to see a PCP. And their first option here in sort of this part of the page or the slide is to give somebody a medication or refer them out for psychotherapy. And if that doesn't work, you can change the dose, you can change the medication, or we can add other medications to try to augment or combine the efficacy or boost the efficacy. And if that doesn't work, we often will call somebody treatment resistant, which is kind of a defeating word. But then they're offered things like TMS, ECT, ketamine, and as a last resort, they may get experimental deep brain stimulation. And so this is sort of the workflow that we go through in Canada, and in the US too. I think it's very similar. So brain age has been studied at multiple levels here in terms of people's course of treatment. I'll highlight a few studies, and unfortunately, a lot of the evidence is mixed. So to look at, first, many people have looked at brain age in the context of pharmacotherapy, and I'll highlight two studies in particular that looked at brain age in the context of SSRI response. So one study found that a lower brain age, the same study that replicated our impulsivity finding, this was a placebo-controlled trial called EMBARK. What they found was that people who had a lower brain age responded better to sertraline, which is a common SSRI. I think it's Zoloft, relative to people assigned to the placebo arm. So this is just an example. So on the left here, you can see treatment improvements in suicidal thoughts, for example, implicated in and sort of change over time to sertraline. And as you can see, people with a lower brain age, which is in the blue line, saw greater reductions in not only suicidal thoughts, but also impulsivity and overall depression severity relative to individuals with a higher brain age. And this effect was not seen in the placebo arm. However, then this is the mixed part, is that there are other studies showing no significant association between brain age and medications. And in this case, this wasn't a placebo-controlled trial, but rather a much more naturalistic trial comparing or trying to identify biomarkers of response to an SSRI called escitalopram. And also, people who didn't respond to escitalopram got an antipsychotic augmentation if they didn't respond. So again, it could be different treatments, different treatment designs that might be causing for a lot of, or that might be driving a lot of this variability that we're seeing here. Now, what about TMS? So I've got a couple of studies. One very recent one looked at TMS over the dorsolateral prefrontal cortex, an area of the brain implicated in executive function. And they were using stimulation on this area to treat people with late life depression, but they also had a comorbid cognitive disorder like Alzheimer's or another neurodegenerative disease. And they found that people with a lower brain age tended to respond better on in terms of their depression symptoms relative to people from an older brain age. So this is the 3rd week after treatment, and remitters just means that they no longer meet diagnostic criteria for depression. And as you can see here, their brain age is significantly lower 3 weeks after treatment relative to non-remitters. However, we found in our study that at least to dorsomedial stimulation, which is another area of the brain implicated in emotion memory, or sorry, emotion regulation, we did not see a significant association with active treatment, but actually a significant association with placebo, which was really surprising. I did not expect that. Such that individuals who had older appearing brains had a greater placebo response. It was very hard to make heads or tails of that finding. um, so moving on, mixed findings in terms of that brain age's association with treatment response. But as I said before, a lot of these studies are stimulating with different, or the treatment designs are very different medications, different areas of the brain we're stimulating, and different clinical trial designs, open label, placebo controlled, number of arms, for example, that might be contributing to a lot of these, the heterogeneity that we're seeing in these findings. So I'll end off with just talking about 3 challenges and how we're working on this in the lab to try and overcome these challenges. The first I want to talk about is how we design some of these models to predict age and sample size. So first is we're using typically hundreds to tens of thousands of individuals to build these models. However, especially with functional MRI, there's evidence to suggest that we need more people in order to really characterize individual differences. The other thing that's a problem with how we design these models is we're training a model to predict healthy aging and then applying it to a clinical sample. And there might be some interpretive problems there. It might not just be the diagnosis of depression that contributes to prediction error. It could be a lot of other things, and I'll show what that means in a second. But it could be things like MRI quality, as well as not accelerated aging per se in the areas implicated in healthy aging, but something different. It could be abnormal aging in other regions of the brain. So one thing I want to talk about here, which actually was developed here locally at UPenn, is the development of growth charts. So instead of building a machine learning model to predict age, Jacob and Richard and others on their team used a really the largest structural imaging data set, over 100,000 individuals, and used linear growth mixture modeling, which is the same kinds of models we use to quantify percentiles in height and weight in babies, but then just applied those statistical concepts to brain volume and in different tissue classes. And they were able to do this at from 121 days post-conception all the way into people into their 90s. So it's quite a robust sample. We tried to apply these models in individuals with depression, and we were able to identify differences in brain aging percentile, particularly amongst individuals with recurrent depression, which means that they've had more than one episode of depression. We were also able to correlate this with cognitive impairment, showing that in healthy individuals, brain centile score was significantly associated with working memory, such that individuals with a poor brain centile score, similar to the people with depression, had poorer performance in working memory. And this relationship between healthy aging and behavior was not present in depression, indicating that the diagnosis sort of breaks down associations between age and cognitive decline. We're also now applying this with late life depression data. This is my student, Dora. I should also mention the previous student, Natalie. And what we'll be doing with this data is looking at late life depression and response to TMS over both the right and the left dorsolateral prefrontal cortex. This was a non-inferiority trial comparing different kinds of TMS, finding that both those kinds of TMS were both equally effective in late life depression. And we also know in this sample that people with treatment-resistant depression have poorer, globally poorer memory and executive function. And so what Dora will be looking at is whether or not brain centile score is associated with cognitive improvement as a result of TMS. Now, I mentioned some of the interpretive problems or hurdles to understanding brain age and accelerated aging. So right now, as we develop these models, we have these model weights that tell us which areas of the brain are really important for predicting successfully brain age or aging. Um, and so, however, though this is sensitive to a lot of things like MRI quality and scanners. So this is just one example where they did brain aging, and I think it was in the Enigma group. And they found that depending on the brand of scanner people were scanned at, brain aging was different depending on the brand of scanner, indicating that not only is brain aging probably some physiological thing, but probably there are a lot of confounds at play here too. So how do we know if in our depression sample, people with depression move more in the scanner? So there may be increased error there too. So how do we know that brain aging is associated with aging, some other factor, or both? And also, what is contributing to the predicted error in the brain? Are there particular regions of the brain that contribute to prediction error? And how do we quantify this? So our group is using something called Shapley additive explanations, or SHAP values, to understand how particular features in the brain contribute to the actual prediction itself. So instead of looking at the weights of the machine learning model and how they predict successful aging, SHAP values give us weights that tell us what values are actually important to the actual final prediction for that person. So you get a value of every feature, brain-based feature, and how important it was to generating the actual predicted age. So this then allows us then to look at, okay, well, this particular area, if the brain is really driving accelerated aging in depression relative to controls. So it might give us a clue as to, okay, are there specific networks at play here, specific regions, and how can we maybe engage those circuits better with treatment? So we did this in schizophrenia. What Pedro did was he estimated brain age, extracted the SHAP values for each individual person and feature, and he was able to show that particular areas of the brain, in terms of their cortical thickness and volume, were contributing to accelerated brain aging in schizophrenia relative to controls. So this included things like the thalamus, specific sulci, as well as the putamen, brainstem, and actually whole brain gray matter volume was a big predictor as well. Okay. The last thing is heterogeneity in depression. So depression, to be diagnosed with a major depressive episode, you need 5 of 9 symptoms according to the DSM-5. One of them must be either depressed mood or anhedonia, and you need these symptoms for more than 2 weeks. However, there are lots of different other symptoms, and if you actually do the math of all the combinations of symptoms that yield a depression diagnosis, I think it's over 250 combinations of symptoms. So we're all diagnosing these people as depressed. However, they can be featuring or describing many different kinds of symptoms. So it could be some of them are gaining weight, some of them are losing weight, some of them have an appetite, others are binge eating, some have comorbid anxiety symptoms, some sleep too much, some sleep not enough, some are mad and angry and irritable, others are, apathetic and have a completely flat affect. And all of these people are diagnosed as depression, and we give them comparable medications. There are different ways we can kind of look at this heterogeneity. One is a top-down approach, where we try to subgroup people based on their symptoms and then look at brain circuit dysfunction in those subtypes. So that would be like your melancholic depression, your psychotic depression, and things like that. This has yielded like interesting subtypes, but they don't actually prospectively predict treatment outcomes. So we've turned to brain-based measures, where we subdivide people based on common brain circuit dysfunction, and then subtype people on that, and then look at, okay, are they different in certain symptoms, or combining the two early on in the subtyping approach. Now, we've done this before, and in depression using functional connectivity, we're able to identify a number of different dimensions of co-occurring symptoms and functional connectivity. And in this example here that we published a few months ago, we were able to identify 2 big dimensions related to depression, a mood-related dimension and an anhedonia-related dimension. this stratified people into 4 subtypes using hierarchical clustering, and individuals who subtyped into the more anhedonic subtypes, subtypes 2 and 3 here, were less likely to respond to either dorsomedial or dorsolateral TMS. So how does this might relate to brain aging? Well, what we'll use is something what we're planning to use, and this is actually in collaboration with Christos here at UPenn, David Zikos. Well, we're going to take symptomatology on a number of different depression items. Previously, what we've done is using functional connectivity, and we use CCA to identify latent dimensions whose linear combinations of different symptoms maximize the correlation, the canonical correlation between resting state, functional connectivity scores, and symptomatology. Now, instead of using resting state to quantify brain aging-based subtypes, we're going to use those SHAP values. So stay tuned. I don't have fun. I just got funds to do this work. So hopefully I can come back in a couple of years and show you guys some cool results there. But stay tuned. So with that, I think I'll stop. I just wanted to first thank everyone in my lab and some of my former students, my collaborators both at U of T, at Cornell, and abroad, especially here at UPenn, who have been really great at providing you with data, but also support with brain centile scores, particularly Jacob and Richard. So thanks.
Great talk. And the TMS results, I think, really interesting as well. So you have in first part of your talk, it is showing that there are differences in network modularity in depressed patients. And then you have in the later part of your talk that brain age is associated with higher brain age is associated with like worse treatment outcomes, especially with TMS. And I think that you can kind of put those two things together to get at the mechanism underlying that TMS effect.
Yeah.
And it would be really cool if you could try to look at the relationship between brain age and functional connectivity with either the actual stimulation site in the network that gets TMS, or like a simulated TMS site in like a large database of depressed people.
Totally.
It would be really, really cool to see like whether or not those networks break down, and that might be underlying sleep difficulty.
100%. Yeah. Yeah, if network, yeah, especially, so the one that where the brain aging study worked, that one was people with late life depression and a comorbid cognitive disorder. So these people already have pretty severe cognitive deficits. So I imagine that those people really are the ones that have like the biggest network segregation breakdown. I think like with a younger sample with less cognitive impairment, the jury is out too with how it works with respect to cognitive impairment in that population anyway. So it could be that it's just the combination of both some of these really severe cognitive deficits in the context of neurocognitive disorders that really is driving that effect, and not necessarily TRD itself. That's my hypothesis, at least.
Yeah, I think even modified seed-based connectivity in young versus old depressed folks will be really interesting.
Yeah, absolutely. Well, we can chat this afternoon. I have some data that I will hopefully that late life depression data from Dan, Bloomberger. So we will be looking at some of that kind of stuff too. So also I've tried to like apply late life depression data into our clustering subtyping approaches, and it fails to replicate in an older sample, probably because of the age-related cognitive decline and some of the differences in pathophysiology in that population. Thanks. Yes.
Explain more about how the brain age estimation works, like how the kind of criteria are counting when you're quantifying the age.
Yeah.
Let's say what kind of people are in those samples who are used to estimate.
Yeah, that's a great question. So I kind of glossed over what kinds of machine learning models are used. Some use SVMs, some use other more complicated measures, boosted measures as well. Others have feature selection steps, others don't. There's a lot of variation, but the gist of it is we use a really large sample of healthy people and across the lifespan, and we use that as our training set to predict age. We then apply that model once we've tuned it using cross-validation schemes or independent data, healthy data, and apply that to our clinical sample. So the model is trained on healthy individuals, which we then apply to unseen clinical populations to see whether or not the deviations in predicted age are greater than our healthy group. Yep.
There also, it seems like this model is a longitudinal model, and let's say this is generalizing the, let's say, people who are in their 30s, like, well, nowadays, and people who are 30s and like 20 years ago. And I was a little bit concerned about the possibility that there might have been some confounding factors. Let's say there could have been like a worldwide trauma 20 years ago.
Yeah.
And,
Yeah.
and would that be, would that have the same weight in the sample?
Yeah, that's a really great question. I mean, there are a lot of, I don't do a lot of trauma research, but I do know that there are studies out there looking at differences in people resilient or vulnerable to trauma after like environmental disasters and things like that. But I'm not super well versed on that literature. You're right that typically isn't accounted for, but I think it's more with these larger models, especially when you get into the tens of thousands. And often these data are used, or these data sets involved like multiple like countries, and it's not just like one city data or something like that. It could be from many cities across a decade. We're kind of working with secondary data here. And so hopefully by you're leveraging quantity over quality, if that makes sense, in order to characterize a lot of these models. Thanks. Yeah.
I'm interested in how the treatment itself affects brain aging and also the functional connectivity in the brain.
Mm-hmm.
Have you ever looked at like if EMS or antidepressants slow down the brain age?
We don't know. So a lot of this stuff is cross-sectional. So we don't really know. So the Manish Jha the paper looking at response to sertraline that showed the effect with sertraline relative to placebo, they did look at retest reliability, but I think that their second scan was only a week into treatment. And so it's not enough time for an SSRI to really change a whole lot, especially structurally. And so they didn't see any really strong changes from one baseline to 1 week into treatment. Whether or not remission or response long-term reverses the effects of accelerated aging, we don't know that at all, especially in the context of depression. So we do have longitudinal imaging in some of our TMS studies. So the late life depression sample I was just talking about has pre-post imaging. And so Dora will be looking at that, hopefully, if she has time. And a lot of these samples do have post imaging, but it's challenging to interpret too, because is it a true benefit? Are we reversing something, or is it like they moved less in the second scan? It's kind of hard. There's a lot of things we have to think about in terms of potential confounds. So it's sort of an interpret cautiously kind of endeavor. Yeah.
And I was kind of curious, like, the interpretation of that, especially the part where, I guess, like different, different brain regions are more, like it seems like it kind of broke down. And I was just kind of wondering,
yeah,
behavior or like aging.
Yeah. So aging happens non-linearly, and so does cognition or age-related cognitive decline. But when we think about a network, like there's a balance between randomness and structure in the brain, and we want efficient transfer of information from one node of a network to the next. And our brains are organized in a way that there's like just enough inter-network connectivity so that we can efficiently flow information from one node to the next. And as that starts to break down, it could be due to white matter hyperintensity burden, which we get these little structural deviations as we age normally. It could be to demyelination. It could be to a lot of different inflammation, a lot of different factors that contribute to this that we don't fully understand. The network starts to break down and it becomes less efficient. So as it starts to break down, and information can transfer in a less efficient manner from one node to the next, which is probably causing some of these disruptions in cognitive performance as we age. Thanks. Great question. Any others? Mm-hmm.
You talked about this network clarity and you also look at like white matter density in general.
Not in these studies. So the brain charts looks at white matter volume over time. There are a lot of studies looking at white matter in the context of like white matter hyperintensity burden. So as I said, you get these little structural deviations in white matter as we age, but not density per se. Myelin mapping, I think, it's an area I'm only starting to get into through some collaborators in the context of depression, and it's a very indirect measure of white matter and myelination. So there are some caveats with the context in the context of MRI, but in quantifying white matter hyperintensity burden, like there are some really cool tools out there looking at like what white matter tracks in the brain are being affected by particular white matter hyperintensity loci, and then looking at what areas and networks and how that might contribute to cognitive decline. A lot of really cool work coming out of Cornell, actually. Amy Kujewski at Cornell is doing a lot of that work. She's like developed a tool to do this. It's like a normative DTI tractography sample. You just like put a little ROI where the white matter hyperintensity is, and it will tell you where you go from there, which is kind of cool. And so we have looked at this and trying to combine some of those tools with functional connectivity. Abhi Jaywant was the sort of lead author there back when I was a postdoc. But yeah, there are attempts to sort of look at the relationship, lots of attempts to look at white matter hyperintensity burden, what networks that's affecting, and how does that relate to behavior. Yeah, sure.
Does that also increase that capacity?
Ooh. I mean, these happen as we age normally, and most of them don't really cause any significant cognitive problems. And I don't actually know about risk for seizures, and that I don't know. Yes.
As to how psilocybin or other psychedelics might change depressed brains relative to like, the other treatments that you showed?
Yeah, so there's evidence suggesting that psychedelics increase or decrease actually the modularity. So areas of the brain that are not typically functionally connected become connected during a trip. How that, I'm not, again, I don't do a lot of psychedelics work, although we're starting to get into it a little bit at my site. I don't really know how that might relate to aging. It's still in really early days, but really would be really cool to look at though, for sure.
Said that like correlations between areas that typically aren't connected is like a bad.
Yeah, totally. And this is just it. What I'm talking about when you're actively tripping, essentially, you see this functional connectivity between regions that aren't typically connected, but it's transient for the most part. And so what that means in the context of aging isn't really fully understood. Yeah, be really cool to look at though. Somebody give me data. Yeah. Yeah.
Is it always exciting?
Sorry.
Sorry.
So when you mean excitatory, like glutamatergic, like, oh yeah. So so changes in functional connectivity, like fMRI is an indirect measure of brain activity. So it's not necessarily like it's not like EEG where we're looking at local field potentials. We're actually looking at changes in hemodynamics. So generally when areas of the brain are active, and that may be likely due to pyramidal neurons in the cortex, for example, it increases local blood flow to address metabolic needs. That's what we think happens. That change in blood flow, deoxygenated and oxygenated blood interact with the magnet of the MRI in different ways. And so when there's a rush of oxygenated blood, it causes an increase in the signal intensity. So we're kind of using blood as an endogenous contrast, which is kind of nice. But it's indirect. So, and there's still lots of debate on like how or why and to what degree that relationship between brain activity and vasodilation occurs. It's probably through astrocytes, that have sticky feet on the capillaries as well as on probably glutamatergic neurons, but we don't fully know. No, no worries. That's a great question.
We'll end it here, and if
Great.
anyone else has questions, ask our speaker. Thank you very much.
Thanks for having me.